Hi, everyone. Welcome to the Room Now daily recap. This is where our faculty gets together with some wine, some beer, or maybe just a bottle of water and rehash the day for you. Welcome to the Room Now daily recap. This is where our faculty gets together. That is the live stream on YouTube. So we're on multiple channels here. We're live for you guys that have signed up for this, and then those who are out there in the netherworld, they're listening to this on YouTube. I'm joined by the Room Now faculty. I'm going to tell you where they're from, and they're going to get into it. Aurelie Najam, Aurelie is from Glasgow. Richard Conway is from Dublin. Bella Mehta is from Special Surgery in New York. Pedro Castillo is from Dallas, Texas, and UT Southwestern, and Yuz Yusof is from Leeds. I'm Jack Cush in Dallas as well. We're glad to have you join us and partake in this exercise. If you have any questions, we have a chat field. A lot of people like to put their comments down about what you agree or don't agree with. If you have any questions for the faculty, just jot those in there. We'll try to get to them at the end. What we're going to do is we're going to review abstracts, great debate, plenary session, afternoon stuff. Let's go, and I'm going to open it up to the faculty. Anybody want to talk about an abstract that they liked from this morning, a poster abstract?
Yeah, if I may start. So I don't think I am. Can you not hear me?
Oh, we can hear you.
You can hear me. That's good. Right. So yeah, there's one that I actually really liked, number 141. It was actually looking at influenza vaccination coverage in our population. And so we kind of know already that this coverage is suboptimum. I think one of the issues they highlighted that I thought was really interesting was that basically some of the factors that were associated with that were just patients' concerns and beliefs, which basically means that this is easily addressable. We need to speak to them. And because we're in the situation where we are giving boosters for COVID-19 anyway, I think it's the perfect opportunity to just talk to them and to maybe, discuss to also give them the influenza jab as they get their COVID jab. That was just like, simple message that I thought was quite interesting.
I'll remind the audience that if you're a military recruit, you get about 29 vaccines at a time via pneumatic gun. So the idea of giving multiple immunizations at a time is a well researched sort of concept. Anybody have any other reactions to this particular poster? Okay. Anybody else have a good poster they want to bring up?
I think I can go with, Yuz, you can start. I can
go ahead, Bella.
Okay, so I think one of the posters in the autoinflammatory realm was JAK inhibitors, and see if they help in JIA or still adult onset Still's disease. And these are patients that are difficult to treat. And sometimes when they're refractory, there's a lot of talk about JAK inhibitors or trying them. But I think one of the main message from the poster was that it's individually like a monotherapy. I don't think JAK inhibitors are cutting it. They're not helping us getting the steroids down too much. But I think as an adjuvant therapy, it probably can work in some of these patients with adult and pediatric Still's disease.
So I'm interested in that too. And it was 8 patients from France. Most of them were systemics, and no remissions with the JAK inhibitor. They were refractory patients, by the way, right?
Yes.
So they failed other things. There were no remissions, and half of them had a partial response. The literature is full of a lot of anecdotal reports of JAKs looking really good in systemic JIA, right? And
all these case reports that have been popping up, but this is like a little more. I mean, it's a case series, but in Still's disease, even for 8 patients, it's it's good amount of data.
It speaks to the need for trials to base your practices on rather than case reports. But that was enlightening. Yuz, you had one that you want to talk about?
Yeah, so I've got a poster that I'm quite interested on. It's poster 0133, abstract number. So this is about cancer rate, cervical cancer screening rate. So because we're all now busy with COVID pandemic, so I think we shouldn't be, we shouldn't forget about other things that are important as well. So they were looking at, the time, between the screening, and there was a delay. So the mean average of the screening was about 4.5 years. So usually the recommendation is about 3 years, and there's quite a different various guidelines. Some say 1 year, some say 3 years. So there's quite a variability there. So, but importantly, certainly there's a delay there. I mean, that was the average 4.5 years. And of this cohort, 4%, sort of 4 people, which is like 4 people develop sort of cancer out of 140 patients that they looked at. So I think this is something that we need to to look into lupus women particularly. Yeah.
So those were lupus patients in that cohort.
Yeah,
right?
lupus women. Yeah,
Yeah,
because we know that lupus women have a high rate of cervical dysplasia
Right.
because of suppression. Yeah.
There's a little bits. I was expecting to write an article at some point about the consequences of COVID, all the missed appointments, all the things that should have happened, didn't happen. Actually, Richard, you found one today about testing, didn't you? Did you see it? Was that your tweet today about the intervals between testing during the COVID era that they were?
And the laboratory testing, that patients weren't getting their liver function tests. That poster was in particular about done at the intervals they should, less than 50%.
Yeah.
And even despite the best efforts of the authors of that, they didn't improve it above 50%.
These things have happened, and I think that we're to blame. My opinion is we are to blame because we were just dealing with COVID as best we could. But how many of us actually had mass mailings to patients about don't stop your medicines, don't worry, you're not going to die at home, from this bug coming in through the windowsill. Make sure you make your appointment, make sure you get your labs. You need to see your primary care. I mean, nobody did this. We were just hoping patients were to call and ask for questions, and many did, but there were a lot that didn't. And these kind of events happen. I think that's now. Luckily, we're coming out, I think, of COVID certainly by mid next year. This is going to be done with, but there's a lesson to be learned here.
Do you think we?
Go ahead, Richard.
Do you think we could or should have done that, Jack?
Say it again.
Do you think we could or should have done that?
Yes, I think we should have. I think it should have, but I guess, this caught us by surprise. But I think we knew by, started March of 2020. I think 6 months later, we should have been more proactive. The college did a good job of getting data together for us to tell our patients. And turns out a lot of those recommendations that I even criticized were probably correct about, holding certain drugs and in certain situations, and then the updates saying what drugs to hold during vaccination. But I think that our interaction with our patients is it's something that we'll always spend our whole career working on, and this challenged us even a little bit more. So
I think
you're going to say something, Pete.
Yeah, I was just going to say, with the evolving information, it was a little bit difficult, I think, even for us, even if we had communicated with them, knowing exactly what kind of recommendations to get. I mean, sometimes it was from Monday, I would change something that I was saying on Friday, but I think this is a great opportunity because these are the kinds of things that are going to happen. And when they happen, it should at least, the silver lining is we know what things we were good at, we know what things we were not good at, and we can work on preparing for the next time something like this happens. I mean, and the next time might just be another COVID variant, right?
Right. Who else had a good poster to mention here? Richard?
I had one, Jack. It was poster 120 by Beth Wallace from Ann Arbor. It was looking at fibromyalgia in rheumatoid and how that determined long-term glucocorticoid use.
So can you define the fibromyalgia-ness? I accuse my in-laws of that all the time, but does it actually have a definition?
So there's this thing called the fibromyalgia survey questionnaire, and if you get a certain score on that, it classes you into being low, moderate, high, very high risk of, or very high fibromyalgia symptoms. And essentially what she and they found was that if you were in the high or very high groups, you were much more likely to be on long-term glucocorticoids, odds ratio of 5 for that.
Wow.
So we're essentially treating fibromyalgia with steroids in people who have rheumatoid arthritis and probably making it worse.
My surrogate for that Pete and I use in clinic is a one-page survey that patients get to mark up what hurts today, how much pain do you have, what review of systems. And the more ink that they put on that thing, the more that fibromyalgia score goes up. And I think that there should be a big red flag when we see that. I like that paper. I was a little bothered by the term, but I think it has a strong teaching point. Yeah. All right, let's go on to the great debate. Voclosporin versus belimumab. First off, let's see how this panel would vote. I think the vote went something like, your patient's not controlled on mycophenolate. What are you adding? And let's say it's in the first 6 months of the disease. Are you adding belimumab? Raise your left hand. Okay, and you go on voclosporin, raise your right hand. All right, it's like top row versus bottom row. It's a standoff. All right, so who wants to use you're our lupus guy. You probably spend more time looking at lupus than all of us. What did you take away from that debate?
Yeah, so what I take away is it's all about personalizing therapy. So you can't treat everyone, make it standardized. So it has to be on the patient's features. How bad is the EGFR, whether do they have certain extra renal manifestation at all. So then after that you can balance up whichever you prefer, voclosporin or belimumab.
Yeah, Lake of Barbosa and Dallas mentions the vote actually went in favor of voclosporin. I would argue this panel is a little bit more intelligent than the audience, and that's why we were split. But then again, I'm probably biased. What I liked about that debate was the two debaters didn't really differ in their opinions. They made their case for their drug, but they both said, we should be using these drugs. And I think many of us probably aren't using these drugs. And that's sort of another issue. Let's, Aurelie, what do you think about, why were you in favor of voclosporin?
The thing is, it's quite, as Yuz was saying, I mean, there's so many different, type of diseases, to so many different phenotypes. I think it's really difficult. It has to be a case-to-case decision. I think overall, I was maybe more convinced by, these data, but I mean, it has to be a case-to-case basis. I would not say just give that to everybody. I would not say that.
Going with the calcineurin inhibitor, I think it has more biologic interjections than does a B cell specific agent. And lupus is many different kinds of disease. There's a B cell driven disease. There's a interferon alpha driven disease. There's probably a myeloid driven disease and whatnot. Virginia Pasquale showed that a few years ago. And maybe you get a little bit more coverage with voclosporin. That's kind of why I'm on your side. But Bella, you like the belimumab data. Why?
I think the way the voclosporin trials, I mean, they're good, but when you actually read them, the way they dosed other things, like say even rituximab, it's not how we usually do it in practice. And I think the other thing is that access, right? We've been using belimumab; it works. I don't know. It always is difficult to suddenly change what is working. And if it's not, then yes. And again, it's going to be a case-to-case basis, but I'm saying that it's not going to be the first thing I'll do.
I think one of the reasons why a lot of people went in for belimumab, I think they can see they more safely add belimumab to mycophenolate. I think people worry about the safety of adding the calcineurin inhibitor to mycophenolate. You're going to say, Yuz?
Yeah, I think maybe because it's a different geographical region as well, experience. Because you guys from America have been using belimumab more. I mean, in the UK, the trial was positive 2011, and we only got to use it at 2017. So we have not really had much experience. And I actually had published cases before where we used. So we found two patients had lupus nephritis on belimumab. One which is like new, they've never had lupus nephritis before, which we published. So I mean, it's only at small numbers, but certainly it wouldn't stop me from using it in the future. Yeah.
Yeah. Richard, your opinions on these therapies?
Yeah, I'm in Ireland. We don't have either of these drugs, so I won't be using either of them. I'll be using tacrolimus. But my reading of the data from the trials is I actually like the renal outcome data better with belimumab. And there is this thing about voclosporin having an effect on proteinuria that isn't actually correlated with the actual renal outcomes.
Right.
So yeah, slightly going towards belimumab, but not having strong feelings. But then again, who am I to disagree with Michelle Petrie?
Well, actually, Dr. Castillo disagreed with her, and Pete, you have access to these drugs. Do you? Which have you been using, or?
Well, I actually ended up voting on the side of Benlysta, but I think, or belimumab, but it was, it's basically because it's a binary question, right, or an answer, which is difficult because obviously it's a case by case basis. I got to be honest, though. I feel like in my experience, I feel like the nephrologist is often the one that ends up choosing these treatments. And so I was wondering what the rest of the panel thought about that, and when do you step in and sort of, give your opinion that, hey, actually, I think that I know you were going to go with, belimumab or the other, and I think it should do this one.
And I think that reflects where you practice. I think some of us are. Don't use nephrologists very much. I mean, I seldom would use a nephrologist. And when I was a fellow at UT Southwestern, Pete, we had a nephrologist working in our division, but we didn't really get involved. And then after I left, a lot of lupus patients ended up being managed by nephrology. So I think it depends on what the local practices are as to whether nephrology is there, and they'll use a whole lot more tacrolimus than anybody else. But who does co-management in this group with nephrology? Most of the group. Okay, so that's kind of where all of you are. Any last comments about this this debate? I think it was a good subject. Yeah, most of you are in agreement. All right, next was a really hot session on the plenary session, which discussed a lot of different things, from risankizumab to lupus nephritis and health disparities, abatacept, cognitive dysfunction in lupus, and then immunosuppression with COVID. Anybody want to tell me why one really stood out for you? Richard?
I suppose I can talk about risankizumab. It certainly works. My big thing with these drugs is we've got so many of them now. I don't know which one to use. It's like, how do we choose between them? We're picking up these little tiny pieces. Maybe this is better for enthesitis. But really, I don't know. And I think we need to know that. We need some head-to-head trials.
Yeah, and well, there's a few things there. One, I have a good friend in Brooklyn, Dr. Ricciardi, who says, I got more drugs for psoriatic arthritis than I have psoriatic arthritis patients, and he too is bothered by this. It's good to have options. Rheumatologists like options. Dermatologists have been very swayed by head-to-head trials where IL-23 has looked very, very good. IL-17 basically knocked down the TNF inhibitors, IL-23 and 12-23 first, and then now 23 has done the same. So I don't have anybody on risankizumab. Actually, I have maybe one or two, because it's largely been only indicated for psoriasis, but it's going to get a the psoriatic arthritis indication. Has anybody else been using this? Not so much yet.
I guess the insurance companies will tell us what to use in the other way around. If we don't know, they'll tell us. So we need to find out.
You need to move to Texas, where patients can sue their insurance company for malpractice, and so we're a little bit more able to push the envelope. Now, yeah, someone would have to with psoriatic arthritis at least have to fail a few drugs before you could put them on either the Tremfya IL-23 inhibitor or the risankizumab, the Skyrizi drug. Anybody else like any of these other plenary sessions?
Yep, so I found quite interesting presentation from Professor John Henley about cognitive impairment in lupus. So we do, quite a lot of our lupus patient always complain about brain fog and quite remember attention span and everything. So they found that in their unselected cohorts, there were about 48% people did have cognitive impairment based on the test. And then quite a majority of them had lupus anticoagulant positive as well. So what they found, so they did two types of MRI. So they did one, the functional MRI, and also the other one is DCE MRI. So the DCE MRI can pick up if there is a leakage in blood-brain barrier. So I think first what they found is they found there's quite a lot of functional abnormality in terms of connectivity using the functional MRI in people who have cognitive impairment compared to lupus patient without cognitive impairment and also healthy control. And also what they found as well, there's also increased blood-brain barrier leakage in people with cognitive impairment. So that's why they thought, they will do more work on this, and potentially blood-brain barrier could be a potential target in the future. So I think that probably quite interesting as well.
If you do surveys, over half of patients with lupus will have neurocognitive manifestations that would qualify as neuropsychiatric lupus, but the number is actually really quite low. And then trying to diagnose subclinical diseases, which is what they were doing today, the question is, what does that mean? Very few of their patients in that study, it was a good study, large study, actually had a prior diagnosis of neuropsychiatric lupus, or what we call lupus cerebritis. The question is, what are you don't do any of those tests, and you don't have access to any of those tests, so what are you going to do? I can tell you, I studied this for many years. Blood-brain barrier is best measured by something called Q albumin. It is the CSF albumin times 1,000 divided by the serum albumin, and it's the number should be less than 9. A lot of lupus patients have, and like 20-25%, and that's what they showed. Somewhere between 10 and 30% of lupus patients had an elevated or leakage of the blood-brain barrier by their much more exact test. But around that number, we'll have a Q albumin that's between 9 and 15. And that's probably okay. The only problem is that screws up your other indices like the IgG index and things like that. But very high levels are not lupus cerebritis. They're infection and vascular events. And there it goes to 30, 60, 100 as your Q albumin. I was hoping that I asked the question, but they didn't get my question about showing the correlated, what you can correlate those results with, or what becomes clinically useful. We don't really know. But this is, I think, one of those subclinical things that we probably need to pay attention to. I like the ARIA study. That's abatacept being given to high-risk individuals who had arthralgias. They were ACPA positive. They had an MRI, and they looked for an MRI outcome was the primary endpoint, inflammation, mainly, I want to say mainly tenosynovitis at 6 months. And, 100 patients, half got one drug, half got the other. It was a clear slam dunk for abatacept versus placebo. The numbers were highly significant. I want to say in MRI scores, improvement in MRI was seen 61% on abatacept, 31% on the other drug. And it was even better for actual avoiding RA, was 8% on abatacept, 35% got RA on placebo. These are highly significant. And then he dropped the bombshell at the end, which was they have 12 more months of follow-up on no drug. And he just said, without any data, that it looks like there's a persistent effect even after the drug was discontinued. The question is, are you going to treat preclinical RA when it shows up in your office? Few tender joints, who, what do you think? Aurelie.
See, the thing as well that they mentioned, and actually, I don't know if you guys remember the Prairie trial a few years ago. I mean, it was quite a bit the same thing. I mean, it was a bit different, of course, with rituximab, but it kind of reminded me of that. But now what they say as well is that you needed to treat 3 patients to have one with an improvement. What do you think about that? Would you say, I mean, I would wonder if I would, go straight to, if I go straight to a patient, I would say, okay, take it, but you have 1 chance out of 3 to get better. What do you think?
Yeah, I'm probably not. I'm still going to stick to my guns. I'm only going to treat synovitis with DMARDs. Everything else is symptomatic management. And it's a little bit like clinically quiescent, serologically active lupus. You know, they look good, but their labs say they're not. How much are you going to worry? You know, being CCP positive gives you a 20 to 60% chance of progression to RA. You have a positive MRI, it starts going higher. So you just end up following these people more closely and doing something with them, I think. Any other comments on that in preclinical RA?
Yeah, I'm not terribly enthused about it at all. Like we have a abatacept, a drug we know works for rheumatoid arthritis. We give it to these people with pre-RA and they get better. Of course they do. Like it's the 6-month data, certainly completely expected. If there is 18-month data that holds up off drug, that would be more interesting.
But there are larger. There's I want to say it's the ARIPA or a PIPRA study. It's a much larger trial, also being done with that abatacept, and there's something called the Stop RA trial being done at Pete Center in Texas, which is hydroxychloroquine interventions in that high-risk group. So we'll see. We need more data to make smarter choices with our patients. I think that was about anything else from plenary. Otherwise, let's close up with anything else that you saw this afternoon that was great. Pete, did you see anything else during the day that you thought was worth mentioning here?
Yeah, well, let me see. Is this one? I did think that there were a couple of posters on antiphospholipid syndrome that were pretty interesting. There was one that just sort of went over the incidence. I think it was in the Georgia registry, and secondary APS and SLE was about 14% of patients. And I found that kind of interesting just because, you know, I don't think that we always check for antiphospholipid syndrome, but there was some data that showed that patients with positive APL have a higher risk of developing nephritis, discoid rash, malar rash, serositis, and neuro manifestations, kind of going along with the talk we were discussing earlier with neuropsychiatric lupus. And so it was just really trying to push the idea, or really, you know, presenting the idea that maybe we should be a lot more cognizant of that and test for those antibodies in those patients. Dr. Petrie also had something where she looked at lupus anticoagulant patients who were negative and then went to positive, those who were negative or positive and then later developed thrombosis. And there was, of course, some benefit to hydroxychloroquine in the patients who were positive. In fact, some of those patients who were positive became negative on treatment. So those are just some interesting things with lupus anticoagulant and APS, I thought.
Michelle showed last year really convincingly that LAC is much more predictive of events and being truly sick than is antiphospholipid. I worry about antiphospholipid antibodies as being epiphenomenal, almost like vitamin D. It's always bad in people who are bad, and you know, it may not truly be pathogenic. We know when it is pathogenic, but it's not going to be in everyone. We only have a few minutes left. I want to go around the horn and see who's looking forward to what. Bella, do you want to start? Is there anything that you're looking forward to in the next few days?
I think before we go there, there was one thing that there was a lot of talk in the OA community hubs talking about tanezumab, the nerve growth factor inhibitor, which is now basically being pulled off. Mm-hmm. And I think I'm just looking forward to learning more over the next 2-3 days.
Okay. Richard?
Yeah, I don't have any particular sessions, but I think there's so much excellent stuff coming up. We're just falling over as I was trying to see all this stuff. There's so much brilliant content coming out.
Yeah, it's the fire hose of information that is ACR, but that's why you guys are the faculty and the experts to find the good stuff. Aurelie?
Yeah, I mean, I'm having so much fun so far. I'm sure it's going to continue. I'm looking forward, as pretty much everyone, I think, to hear more about all the JAK inhibitor safety, all the issues around that, and quite a few nice presentations I'm looking forward to. There's a nice work looking at meteorology condition and RA activity. I think it's going to be a nice one. We hear that a lot in patients. So yeah, I'm looking forward to all this stuff.
I'm going to throw out some questions. I'll actually answer them, but you guys comment if you want to. Is treating pre-RA or early RA different than treating palindromic rheumatism? All very different. You know, preclinical RA is very different. Then the next thing along the spectrum, which is probably palindromic rheumatism, which is very different than early RA. And so treating them would therefore be very different. Anyone concerned about the kinetics of voclosporin responses versus belimumab responses, that, voclosporin might work faster. It seems like it takes a little longer with belimumab, and that's been my experience as well. I've used other calcineurin inhibitors. I haven't used voclosporin as yet, but I think there's a kinetic advantage there. But, belimumab, the data is there. If you saw Michelle Petrie's plots today on where it starts to separate, and it looks like it does take a few weeks. And lastly, accessing these drugs via insurance, it's going to be a problem in Canada. It's going to be a problem in Dublin. It's going to be a problem in a lot of places. But I think that it's being positioned as sort of a tertiary agent. There's initial therapy, which is pretty simple in lupus. Then there's aggressive therapy, the thiopurines and mycophenolate and even, Cytoxan. And then you have these newer drugs, and that's probably where it's being positioned. In those positions, write the letter that says to not give this life-saving therapy would be medical malpractice. Write it. Go on and let someone try to deal with that. Someone's going to get a nervous stomach over reading your letter when it says something like that. We have an example of an appeals letter that Catherine Dow and I wrote on Room Now for people to download. All right, folks, thanks so much for your time. Hope you enjoy the rest of the meeting. Everyone out there, tell your friends to tune into these recaps. We're going to do them again tomorrow night, Sunday night, Monday night, and then Tuesday night, we're going to have the rheumatology roundup with Artie Kavanaugh and I. It's going to be an hour session. Take care. Bye-bye.
Bye.